Hi, this is Brian Kim. I'm going to share with you case number 69 in the Best Way to Do Cataract Surgery series. So this patient has an eccentric pupil, and so I'm going to show you why and how the corneal marker really improves the capsulorhexis size and centration, and this is why I use the corneal marker for all of my cases. So I'm using a cotton tip to help center the eye. I'm using the corneal marker, which will help me to center and size my rhexis. You can see that the pupil is more dilated on the left side than the right side, and you'll see that as the case progresses. So I use a cotton tip to steady the eye and to make my paracentesis on the right side and then the left side, making sure that the incision is parallel to the iris plane, which will allow me to achieve a self-sealing corneal incision. I inject some intracameral lidocaine and then dispersive viscoelastic. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and just shy of the angle of the blade, I enter. I inject some more dispersive viscoelastic to fill the anterior chamber, which I believe helps me to control my rhexis. So this is a puncture style rhexis. I puncture the center of the capsule, pull it down, grab the right side of the tear, and then go around counterclockwise using the corneal marker, which will help me to center and size the rhexis. So you can see the rhexis seems to be wider on the right side and kind of smaller on the left side. But again, that has to do with the eccentric nature of this pupil. And so I actually centered the rhexis over the visual axis. And so even though the rhexis looks decentered, again, it's not because the rhexis is decentered, it's because the pupil is eccentric. And this patient may have a little bit of a floppy iris. So this is a capsular fornix hydrodissection technique. I place the cannula out to the equator, contra-incisionally, get a nice wave. I tried to turn the lens, it didn't really want to turn. I decompressed it again. And now it's turning. Using the cannula, pointing the tip down and rotating it clockwise. Irrigating the surface of the cornea, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, place the chopper underneath the rhexis edge out to the equator, pointing the phaco tip vertically subincisionally and dividing the lens in half. Placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, dividing the right heminucleus. Using a little bit of vacuum, pulling that first quadrant up out of the bag, crushing it between the chopper and the phaco tip, and then emulsifying the lens piece. Placing the chopper underneath the rhexis edge around the second quadrant, pulling it up out of the bag, crushing it between the chopper and the phaco tip, and then emulsifying the lens pieces. I'm positioning that chopper and hooking it around the remainder of that second quadrant, and then crushing it between the chopper and the phaco tip, and then emulsifying the lens pieces. That's why I really enjoy using the chopper for all these maneuvers. It's just very versatile. Turning the lens in front of me, placing the chopper around that second heminucleus, pulling it centrally toward the phaco tip, chopping that second heminucleus in half, using a little vacuum to hold that third quadrant, and then emulsifying the lens piece. Placing the chopper around the fourth quadrant, hooking it, and then sandwiching between the chopper and the phaco tip, and then emulsifying the lens piece. Once I started to remove that fourth quadrant, the epinucleus starts to tumble out. I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece, adjusting the sleeve. Polishing underneath the rhexis edge, using foot pedal control under cortex mode, because I know there's some cortical material making sure I grab the cortex, but again, controlling it with the vacuum, not using such high vacuum that I might accidentally grab the capsular bag. It looks fairly clean, so I'm switching to polish mode and starting to polish the lens epithelial cells underneath the rhexis edge. Now I'm polishing the posterior capsule. You can see there's some fine lens material in the subincisional area, and I'm disengaging the cortical wisping material from away from the posterior capsule. I'm injecting some BSS to the paracentesis for the subincisional cortical flush. And as I do this, you can see there's quite a bit of lens material that's loosened. So again, anytime I see some lens material, wispy material adherent to the subincisional posterior capsule, I know there's going to be cortical material that's going to come out with the subincisional cortical flush technique. Once it's loosened, I use the INA to remove it. I inject some cohesive viscoelastic to fill the bag, and then I'm going to use a sweep to sweep underneath the rhexis edge to loosen the lens epithelial cells, and if there was any cortical material, to remove the cortical material as well with this maneuver. Inject a single piece of acrylic intraocular lens into the capsular bag. The leading edge goes in the bag. The trailing edge is out of the bag. Go ahead and place the INA handpiece. Go in with irrigation off, inflate, disengage each haptic off the optic. Go underneath the optic, tilting it, rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag, as well as underneath the lens or stuck to the lens. Switching to polish mode, removing any potential lens epithelial cells and lens material from underneath the rhexis edge. There it is, there's some stuck lens material there. And then now rotating the haptic in the horizontal configuration. All right, switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So you can see the pupil was eccentric, but because I used the corneal mark centered over the visual axis, I was able to get a perfectly centered lens with a perfectly centered capsulorhexis. And so that is the advantage of using the corneal mark. I really think that it just makes it easier, much more consistent, not just for eccentric pupils, but if you have a very large pupil, it does help you to size the rhexis as well. And so this is the reason why I always use a corneal marker to help me center and size my rhexis. I don't have as much confidence in myself to be able to get a perfectly centered and sized rhexis every time. So that corneal mark really just gives me a nice visual cue so that I can have a really nice centered and sized rhexis, especially in the case where there's an eccentric pupil. So I hope this was helpful to you, and I thank you for your attention.